Hello, my name is Tracy Carter. I'm a student in the MSN program at Eastern Kentucky University, and today I'd like to discuss my cognitive behavior therapy and bipolar disorder project proposal. A little bit of background and significance is bipolar disorder is a severe mental disease with a lifelong course and considerable morbidity and mortality. According to the World Health Organization, bipolar disorder is one of the top three causes of hospitalization in people aged 15 to 44. Reasons for medication non-adherence among patients with bipolar disorder include denial of the diagnosis, especially in those with predominant mania. The question that I would like to do the project around is in patients with bipolar disorder, how does cognitive behavioral therapy compared with the standard of care affect relapse, meaning increase in bipolar symptoms, whether that's depression or mania, or increase in hospitalization rate within 6 months? Some of the evidence that I have reviewed is level 1, which is a meta-analysis and the purpose of this analysis was to evaluate the treatment outcomes of patients with bipolar disorder treated with cognitive behavioral therapy plus medications and compare these data with the outcomes of those who received standard care alone. The intervention in the study was individual and or group cognitive behavior therapy plus medication. The control group was the CBT, cognitive behavior therapy, group receiving CBT plus the intervention. The results were CBT could lower the relapse rate and improve depressive symptoms and psychosocial functioning. There was a level 2 study done, reviewed as well, and that was an analysis of variance by Park and Park. The purpose of this study was to conduct group cognitive behavior therapy, otherwise known as CBT, for patients with bipolar disorder and test its efficacy. The intervention was group CBT. The control group was random assignment procedures. Were not employed to decide on the participants' treatment conditions because there are participants who wanted to be allocated in treatment conditions first. The control group showed no significant change, but the intervention group showed a significant amount of depressive and manic symptoms that dissolved. Then there was a qualitative study that was reviewed, and the purpose of the qualitative study was to capture patients' experiences with telephone-based self-help CBT, otherwise known as tele-CBT. The overall aim of this was to understand the patient's experiences with the treatment that might inform treatment conceptualization and dissemination. The design of the study was the data was analyzed without prior knowledge of any trial outcomes in order to avoid any bias in interpretation. The results were the combination of professional guidance and self-help represents an appropriate balance between therapeutic input and patient self-reliance for individuals in need of care. The implementation plan consists of meeting with stakeholders, meeting with the staff involved to explain the process and to field any questions, as they're very important in this process. Receive consent from patients, set a start date of 2 sessions, each being 6 months apiece. Monitor the bipolar patients receiving CBT, how many admissions they've had, monitoring their feelings, their adherence, and that would be done using a tool called MARS, and we'll get into that in a little while. Then we would evaluate the results and share the results with stakeholders to decide whether or not this is a good plan to implement with every agreeable bipolar patient. And then, of course, we would sustain the program. The theoretical framework that this project is based off of is a shared decision-making model, which is a collaborative model where healthcare professionals and patients work together to decide on the best treatment option. This model has 3 steps. 1 is introducing choice, 2, describing options, often by integrating the use of patient decision support. And 3, helping patients explore preferences and make decisions, which would involve education, maybe getting family involved to help explain, make sure that it would be something doable for this individual. Also, the theoretical framework of shared decision-making model has been described as a model of medical care that falls between the traditional model, in which the doctor is the primary decider, and the informed choice model, in which the consumer actively controls the information exchange and decision-making. So it allows the patient to be part of the decision process. The outcome measures utilized in this project would be evaluated by using the MARS tool, which is the Medication Adherence Rating Scale. This tool was created by Donald Morisky. The scale consists of 10 yes or no questions that take less than 1 to 2 minutes to complete. The main purpose is to assess the design to estimate the risk of medication non-adherence. So we want to see if the patients are able to be medication adherent. Some of the questions are, do you ever forget to take your medicine? Do you take your medicine only when you're sick? Does your medication make you feel tired and sluggish? Those are a few examples. I do believe cognitive behavioral therapy will greatly improve adherence with treatment compliance in individuals with bipolar disorder. This concludes my presentation.